This conference will now be recorded.
Welcome everybody to the AnCan Advanced and Metastatic Prostate Cancer Group. I'm Herb Geller, who's moderating tonight's discussion. And before we start, I'd like to just thank our sponsors of Bayer and Pfizer, who are really helping enable this whole operation to move forward expeditiously. And so we will soon begin our normal meeting, but Rick, you have something to say.
Yeah, I do. Foundation Medicine has been in touch with me, and they are seeking anyone who has had a liquid biopsy. That means they've taken a blood sample from you and they've analyzed the blood sample, and only a liquid biopsy, if they've come back with an actionable result. Now, I've been through my lists. I didn't find anybody that I recognize that had had an actionable result. But if any of you have had a liquid biopsy that's resulted in an actionable result, or anybody who's listening to the recording has had a biopsy, a liquid biopsy with an actionable mutation found, I'd really be grateful if you could just let me know, rd@ancan.org or info@ancan.org. And if you're willing, I'll put you in touch with David Marshak, who is our guy at FMI. Thanks.
Okay, well, actually, Rick, they just took my blood today for FMI, and let's just hope it's not, they don't come back with an actionable result.
Well, maybe we hope they do, because then that would point out something good for you to do. And I actually did. I gave David a heads up that you were in the pipeline.
Yes, they took 2 tubes of my blood today. So, and before we start, I just want to say, you know, last week you heard Rick really essentially remind me that we have to be our own best advocates. And based on that, I emailed my medical oncologist and said, you know, I would like to do a liquid biopsy. And he wrote me back saying, well, I don't do many, blah, blah, blah. And I wrote him back and I explained exactly what I would hope to get out of a liquid biopsy. Maybe we'll find out that the tumor has mutated and maybe we'll find an actionable result. And he immediately ordered an FMI liquid biopsy. So there is a thing to stand up for yourself. And I have to tell you that this is Dr. Carducci, and he's really been pretty responsive. The other thing is, we thought that I should have a Pylarify scan, and that NIH couldn't do anymore because it's approved. Would you believe? They only did it before it was approved. But I called up the radiation oncologist Collins at Georgetown, had a 2-minute conversation, was mostly focused on why doesn't NIH treat you like a patient instead of a lab rat? And he immediately ordered the test. So I think my own experience is that really if we are our own best advocate, we can make things move forward in the right direction. And thank you, Rick, for all of that advice. So to everybody, I just want to share that. And before we move on, Carl, do you have an update for tonight?
How'd you guess?
Okay. And Sylvester, do you have anything?
No, thank you very much.
Okay.
Herb, based on your comment, can I make a segue?
Sure.
Okay, I just saw today that FDA has approved the GA68 PSMA scans. There's some kind of kit which will make it significantly more available across the country, where you don't have to go to special labs or anything. So
wow,
that's good news.
That's really good news. And
yeah,
I think
I posted it on our Facebook page, and I'm sure some people knew about it already, but just in case you didn't.
Okay,
Thanks.
so I think we can begin our session, and we have 3 new people tonight. So I think we will start with them. And the way we work here is I will ask a bunch of questions which help introduce you to the group, and then we'll have a group discussion and bring everybody in. So I'd like to start with Eric. And Eric, please pronounce your name for us.
That's Yazjevsky. Yazjevsky.
Yazjevsky. Okay. And how old are you?
59,
59. And where do you live?
Madison, Wisconsin.
Mm-hmm. Right on the lake. And
Close.
when were you first diagnosed?
Beginning of August this year.
Okay. And did you know your PSA when you were diagnosed?
22,
And your Gleason score?
7.
7. So is that a 4 plus 3 or a 3 plus 4?
3 plus 4.
Uh-huh. And are you currently being treated, and where are you being treated?
UW, Madison, and UW Hospital, teaching hospital. Referred there by my insurance because they don't have a urology department, so or my health group referred me to UW.
So, and who are you seeing at UW?
Okay. It was suggested to me that I consult with either of 2 specific surgeons, and I consulted with both of them, and I also consulted with 2 radiologists, and thinking I'm doing responsible due diligence, but in hindsight, you know, they're all from the same organization and they all know each other. So I wasn't reaching very far for second and third opinions.
Uh-huh. Well, that's okay in certain circumstances. So, did they do any scans on you?
Every single one, and plus I pushed myself for the PSMA, which I just got.
Uh-huh. So do you have the results from these scans?
Yeah, all clear except for EPE. So they are saying that if I would go with surgery, I would probably need radiation anyway, which is my question. And I really don't need to take any more time tonight because there are other people. And this is a large group, and it's good to see everybody. And thanks for listening. But my initial thought was, boy, you're not thinking that the fork in the road was surgery or radiation, one or the other. But they're telling me even with surgery, I'll probably need radiation because I'll probably have, they're trying to prepare me that I'll probably have positive margins because of the EPE. So my initial thought isn't really good anymore, and that was, oh boy, if I have surgery, I can avoid the complications from radiation. Now I'm 59 years old. Yesterday I went riding bikes like I do every Sunday with my 88-year-old dad, and I'm so happy that I can do that. I want to be riding bikes when I'm 88, and so that's 28 years from now. I'll be 60 in a couple months. I want to know the difference between what y'all have learned about the long term, I mean between 20 and 30 years from now, of side effects from radiation treatment as a initial treatment compared to if it were just the follow-up, sort of the salvage radiation that I'd get after surgery, should I choose that route. So, you know,
and I think the other parts of that equation are not only where you'll be, but what the quality of your life will be.
Right. And I've heard all kinds of bad things about bowel problems and urinary problems, and I'm going to have side effects from the surgery anyway. So I'm just really on the fence.
So Peter, you just made a comment. Could you take over and see if, give me a hand here?
I'm not sure I posed my question.
Well, I think.
Thanks.
So why don't you go ahead and pose your question, Eric? And then, I mean, there's a few thoughts that we have here, but let's just pose your question. Peter will talk to you and I'll talk to you and we'll go from there.
Thank you. I recently was in an appointment with a urologist, and he sort of dominated, and I didn't get my questions asked, and I'm blaming myself. Like, boy, I had these questions written down and everything, and I never had a chance to ask them. So okay, here's my question. Is there a significant difference in the long-term negative side effects from radiation in these two scenarios? One is if I use radiation for initial treatment without surgery. The other scenario is if I go with surgery and get radiation anyway as salvage. What's the difference in the long term? And do we know this? And I'm talking between 20 and 30 years from now.
Peter, do you want to go first?
So Eric, so I don't want to cut you off because I mean many of us have been through this decision-making process. So this group that you're in is the advanced and high-risk disease. So most of us are Gleason 8s, 9s, or high 7s, and we're facing advanced treatments, chemotherapy, elaborate treatments with recurrent disease and so forth. We do have a meeting that meets every 2 weeks for low and intermediate guys, which is Gleason 7, 3+4, which you have for now, and Gleason 6. And we often discuss this very topic of, of what to do, radiation or surgery, and what are the long-term and short-term effects, and et cetera, et cetera. You might be facing some other things like hormone treatment, this and that, and you're a young guy. So you're kind of straddling the fence between right now, between intermediate and advanced. We don't know which way your disease is going. But next Monday at the same time, we will be having a meeting with low and intermediate guys, and you'll be able to talk to guys who've been going for a long time with either surgery or radiation or both, and talk to them about the effects they had, and which are many effects, including the sexual function and urinary function and so forth like that. But my take is this evening, some of the guys on the call are facing, kind of have their back against the wall in terms of treatment. And we don't want to scare you tonight with advanced disease, because the prognosis for most of us on the call tonight is not great. So probably none of us, we'd all love to live for 30 more years, but probably reality is probably none of us are going to. But on the other call next Monday, that's very likely.
Great. Thank you for explaining that. It sounds like that other group.
Hold on, Jeff.
Before you go.
Jeff Marchi, hold on. Okay? Because I said I'll come in after that. We'll give you a chance. Don't worry. I have a number of things that I'd like to say to you, Eric, briefly. First of all, did the extra prostatic extension show up from your biopsy?
Yes.
And how many cores did they take in that biopsy, and how many were positive?
11 of 12 were positive.
Okay. So that's an important fact. It starts to explain why they're telling you what they're telling you. And you are in fact high risk because your PSA is over 20. And the likelihood is that you will be facing hormone therapy, but hopefully not for too long. Hopefully with a 3+4, you may well get away with under 6 months. And I think that's all the more reason to start off and pull this apart in Peter's group rather than in this group. If you were a 4+4 or a 4+5, Michael Chandler, who you'll hear coming up, has that situation with 11 out of 14, and he's a 4+5. He certainly needs to be in this group because he's going to be facing longer term hormone therapy. And that's kind of where we split. For guys that have to look at longer term hormone therapy, they really need to be in this group because they need to hear about how to manage hormone therapy. Hopefully, over 4 to 6 months, you're not even going to, or 3 to 4 months even, you're not going to notice it. Secondly, the reason they said to you, I suspect that you're very likely to have radiation or hormone therapy in your future anyway, is because the Memorial Sloan Kettering nomogram, which somebody will be kind enough to put the link in the chat window for you, the chat window is the little bubble. If you fill in your details in there, it's going to tell you how likely it is that you will get a lasting relief with surgery alone. And my guess is that with 11 out of 12 and extra capsular extension, it's not very high. And so what they're saying to you is, why go through the double jeopardy of surgery when you're going to have to do radiation and hormone therapy anyway? This is very close to my own heart. This was my own situation. I was a higher Gleason. I didn't have as many positive calls, 7 out of 14, all on one side. But with that said, I only had a 30% chance of success. So I said to myself, which way am I going to go? I don't want to have to deal with surgery if I'm going to have to do radiation and hormone therapy anyway. And I think that's the decision that you should probably be looking at, thinking about right now. What is the added benefit of surgery? And we've heard that's pretty low from some real experts. Certainly Peter's group can talk to you about the long-term side effects. There's no way of surely knowing. I have some long-term side effects, but I got to tell you, it's better off dealing with the side effects this side of the grass than the other side of the grass. So, you know, when you've got a tough diagnosis, and 11 out of 12 is tough, but it's very, very easy to deal with that in terms of what we have today. It's going to be really your decision as whether you want to go through surgery when you're probably going to be facing radiation and hormone therapy anyway. Right. So that's what I have to say. Jeff Marchi, please come in.
Thank you
I just wanted to say that there is no guarantee you're going to have problems after surgery and radiation. I had surgery 11 years ago, radiation 7 years ago. I've had no side effects, no problems from it. I know other people the same thing. So you can't guarantee you'll have an issue from those. You may, but don't make that your one decision.
Okay, thanks.
So I really think, Eric, our recommendation is you join next Monday's conversation. And I think given the advice and what you've heard here, I think you can get more, you will have more information coming to you on Monday.
Okay, thank you very much for the direction.
Yeah,
I appreciate
I mean,
it.
there also is, we also have an under 60 group, which you may wish to join.
For 2 more months.
Eric, have you had a second opinion on your biopsy? Have you sent it away for someone else to look at it?
No.
Yeah, you should do that.
Yeah, Johns Hopkins, Dr. Epstein. Look on the website, Dr. Jonathan Epstein, Johns Hopkins, and talk to your urologist and ask them to send it away for a second opinion, because with that many positive cores and 59 and whatever, you need to have some set of eyes looking at it.
Okay,
Yeah,
I,
and we'd recommend you do that right away. Don't wait till you get to Peter's group. Just call them up and they'll
Right.
know what to do. We'll put the links. We'll put these links in the chat window for you momentarily as soon as we hand back to
me,
Herb.
right. Okay. Well,
Eric,
Eric,
this is Al Latimer. I just wanted to say, don't give up hope. I had a radical prostatectomy at Johns Hopkins 26 years ago today, and I'm
Wow.
hoping to get a lot more than 30 years out of this. I'm still here, so.
All right. Good for
Right.
you.
Don't give up hope.
Thank you. All right.
Great.
Thanks, guys.
Okay.
We can move on. There's a lot of
Great.
people here.
okay, thanks, Eric. We will be waiting for you and updates in the other group. Okay, let's move on. Our second new person, and we'll try to squeeze in 3 tonight, the 3 we have. Michael Chandler. Mr. Chandler. Hi, how are you?
Hi, I just unmuted. I'm 63 years old and just got my biopsy results from a surgeon here at UC San Diego last Friday. Thank you for the education, gentlemen. Out of 14 cores, 12 showed cancer. My Gleason score was a 4 + 5 = 9. 2 of my cores were interductal, which I learned about is not good. Help.
So this is your, so let's go through a few more questions. So when you just got the results back very recently, did you say
Correct.
that? And so that means you were really just diagnosed this very recently.
Yes,
Right.
the surgeon, not surprisingly, wants to do surgery and shared with me I'd be doing radiation after the surgery and hormone treatment.
Okay, so that's great, but I guess the next question that we'd have, so what was your PSA?
6.87.
Okay, and how was that picked up? What made you go through this procedure?
In October, my yearly physical with my primary care doctor, he found a nodule on my prostate. And thank you for your suggestion. My slides have been sent off to Dr. Epstein and Johns Hopkins.
So the 4 + 5 was from Epstein's looking at your slides.
No, it was from UC San Diego Pathology Department.
So at 4 + 5 and 11 and basically 12 of 14 cores, I think then it becomes, what else could potentially help the diagnosis, right?
I've not met with the radiation doctor yet, and through, I forget his name, the gentleman here who had his work done at UC San Diego, I'm getting in with a doctor of oncology, a female Dr. McKay, and trying to get in with her. So obviously the holidays slowing everything up, but I'm having abdominal and pelvic scan tomorrow at UC San Diego, and getting my bone scan soon, and just trying to move forward.
And what about a Pylarify scan?
Is that the PSMA?
Yes, PSMA PET.
Yes, I'm going to try to move forward with that, but the holidays slowing us up.
Right, I mean, everything. But I think, all right, so my own sense is that you can't make a decision without more information.
Correct.
And I'm not sure we can give you any advice right now other than get more information.
Correct. Get all the scans, and I'm quite a ways.
Scans, and it might. I would also think, in addition to scans, you'd want to have that yourself, your personal genetics, and the tumor's genetics explored. Has that been offered to you?
No, but we're moving forward with that, and moving forward with all that.
Herb, let me just fill in a little bit for you and the guys. We spent a bunch of time with Michael yesterday, some of the people on this call, and we gave him exactly the same advice that you're giving, which is good. So at least, Michael, you see we're consistent around here. And what we said to him was, we were a little disappointed that the surgeon, a junior surgeon that he saw, didn't point out to him that he had introductal. We did. And we gave Michael and Cheryl a bunch of information on that. And what we said to him is, you're probably best off to try and get an appointment with a really good GU Med Onc and let her talk to you about the introductal and what it infers. And then it's going to be easier for her to order the PSMA scan and the sequencing, the NGS sequencing that's needed to get the information, because she's going to understand that better than this surgeon who didn't even point out it was introductal. And to have Michael and Cheryl arguing with the surgeon, and as you well know, Herb, you often get pushback when you suggest these things. We felt that Rana Mackay, who is a very good doctor, and we know her, some of you on the call may know Rana Mackay, she's going to say, yeah, absolutely, this is what you need. So, we said the first order of business is to get that appointment with Dr. Mackay, and we've got some people who are hopefully going to help with that. And but I felt that it would be important for Michael to come on here to listen to some of the discussion about hormone therapy, to listen to some of the discussion about what this NGS sequencing is all about and PSMA scans, because with introductal 4+5 disease and 12 out of 14 positive cause, he's got a longish road ahead of him. Not that he cannot navigate it, and we hope we can bring him through it. But what we really hope is that he'll make the right decisions at the beginning and not find out down the road that he should have done something different.
Yeah, everything as Rick is correct, and spoke with Dr. McKay's nurse today about getting an appointment with her, and so that's in the works. I think we're just wait till after the holiday.
Right. I mean, I think the timing can be better, but I think it's not going to make a big difference.
Right. But I'm curious if there's any. I know that Ben was on the call yesterday. I asked him to come into the call because he does have experience with introductal. Is there anyone else in this group who originally was diagnosed with introductal disease, or is at all familiar or has anything to contribute about introductal prostate cancer? Len, do you have any thoughts on introductal?
I thought Ben had introductal.
Yeah, and we brought Ben into. That's why we brought Ben into the conversation yesterday.
Oh, okay. So do I know anyone else? No.
No, I'm just saying. Do you know any? Is there anything you want to say about introductal?
Oh no, unfortunately, I'm not well educated on that. Rick and Herb, I'd like to ask just a general question to others, because I had an unusual path, because I started with a medical oncologist, and I started off the bat with LHRH, androgen deprivation treatment, to buy time before I got my ducks in a row to figure out what other treatments I needed to do. I don't know has anybody else done that kind of path, or did you just wait for either radiation or surgery or whatever without starting on androgen deprivation.
Well, I mean,
It's not a
Peter,
common thing.
I mean, when I was first diagnosed, Peter, that's the first thing they did was degarelix right away, and then thought about what's next.
Okay, so you and I are similar that way because that's the way I started. Yeah, but that's why it's useful to go to a medical oncologist pretty quickly.
Yeah, but Peter, it's not the same situation because
I
Herb
realize
was
that.
diagnosed de novo metastatic.
Okay.
Right.
And also in your case, one of the reasons they put you on LHRH was because you had these urinary issues, and they wanted the urinary issues to settle down a little bit before they did any sort of treatment. So they said, you know, let's get you stabilized with the urinary issues, and then we'll jump in and treat. So they knew that was I think one of the reasons why they did LHRH early. Is that right?
Could have been, but it didn't do anything to my urinary issues.
Right.
Yeah.
Right. Right.
If I may add, I was 63 and had Gleason 9 with a 2.5 PSA. I had the surgery right away, which was my choice, December 19th, 2017. And ultimately, my PSA never got to non-detectable. And my radiation oncologist, 4 or 5 months later, convinced the insurance company to let me have an Oxyman PET scan, which discovered metastatic disease in 3 spots. And I had it radiated right away, and I delayed starting hormonal therapy, which was a mistake on my part. My own decision.
You see, Steve, I mean, that's really interesting because I think that if a guy comes into this group saying that they're a Gleason, you said you're a Gleason 9, right? 4 plus 5? Right. So if
the more
a
sophisticated
guy comes into this group with a Gleason 4 plus 5 and a PSA of 2.5 and a bunch of cancer, I think the first thing we're going to say to him is get a PSMA scan, because we know that.
I didn't hear it if somebody said it, but I thought that's really a pretty important.
So I guess what I'm saying is that there are certain signs that indicate that the cancer could be worse than what it appears. Certainly, if you're a Gleason 9 and you have very low PSA, that's a big red flag, And so it warrants getting sequencing up front. And to me, it warrants a PSMA. If you're introductal, we know introductal gets into the lymph system. So you weren't introductal. But there are certain things that, to me, your initial team should be telling you what to do so you can make the best possible first treatment decision.
Agreed. The medical oncologists, which were all GU, did not believe in the Oxyman scan back then.
Oy.
So they just, guy at Kettering, the guy at Johns Hopkins, they just didn't at the time.
Well, I think things have, Steve, I think it's clear things have changed.
I hope so.
You know, but I think in terms for Michael's future, the more information, the better. And then I think you can make an intelligent decision about what's happening next. I mean, you're in the hand. I think it's clear with Mackay, you're in good hands. UCSD is a fine place. And so we'll just have to see how, what the results show and move on from there. And I think, Michael, when you get those results, we, come back to the group, share them, and we can and we'll have more discussion.
Thank you.
Michael, I just want to point out in the chat window to the organizers, Joe Gallo mentioned you'll get a good discussion when you chat with Epstein. This is what we said to you yesterday. Epstein is going to love your situation because it was Epstein back in 2016 whose paper really created this introductory category. I mean, before we knew that they really hadn't named it. So he did the prostate cancer world a huge service. And so when he sees somebody like you, it makes him feel good because we know we're on your case and helping you earlier than otherwise would have been the situation. So you'll let us know when you come back. And Joe Gallo, who runs the active surveillance group and moderates also the low intermediate group, will help you get directly in touch with Epstein to see what he thinks.
Yeah,
So
and
you'll be
he'll
able to
talk
talk
to
to
you.
him directly.
Epstein will talk to you. There's no question about it. He will talk to patients. And he's not just a pathologist who likes to look at tissue. He really likes to help people.
Great. Thank you for the suggestion, and thank you for the paper indicating that he was the doctor that found this pathologist.
Right.
Yeah.
Okay. So look, we'll be hearing more from you, Michael, in the future. And let's see how it goes.
Thank you.
So I do want, given it's the holidays, I think we have time. We're going to do another new person. So Warren, in Edmonton.
Hello.
First of all, is it cold in Edmonton yet?
Well, it's not that bad yet. It's only about -15, but this weekend we're forecasting -37 for a low and +25 for a high. So most meat lockers aren't that cold.
I was offered a job in Edmonton and I didn't take it.
Lucky you.
So tell us
and Warren, I just want to say that you have a quasi Edmontonian. Is that the right? Is that what you call yourselves, Edmontonians?
That's what you call people who are crazy enough to live here. And yes, that's the correct term, Edmontonians.
Okay, well, you haven't. He just stepped away from the mic. I think he'll be back any second. But Peter Kafka has very, very strong ties. Oh, here he is. Peter.
Yep.
Yeah,
I just wrote to Warren, let him know that I've got an older son living there.
Okay. All right. Go ahead.
Great. So Warren, tell us, how old are you?
Well, I'm 68, and I've been fighting this nightmare since when I was 58, since 2011. And it's been an absolute roller coaster ride with numerous doctor mistakes. And
right. So why don't we start at the beginning in 2011? Mm-hmm. And so, what made you get diagnosed? And what was your initial diagnosis then?
Well, I was having some urinary troubles, and my medical for my flight medical asked what was happening. Had my PSA done, and I had a 3.5. So that was on the borderline for sending off to a urologist. He did the biopsy, and it showed absolutely nothing. And then they waited another 3 months, and it still showed nothing. But then my PSA went to 10, and they did a third biopsy, and lo and behold, they found something that was cancerous. Although I have my doubts on whether the guy doing the biopsy even knew what he was doing, because he asked me a couple of times or told me I have nothing to worry about before he did even the test. So that's where the nightmare started, and I subjected myself to a prostate removal. Big mistake. I should never have done that, because what I know now, the radiation would have been a much better pick. And,
so you had a radical prostatectomy in 2011 or 2012, is that right?
2012.
And where was that done?
It was done in Edmonton, Alberta.
Okay.
By a rather excitable urologist who wanted to test out his new robot machine, knowing full well that he was going to be using me as a training guinea pig.
So what was the outcome after your radical prostatectomy? What happened to your PSA? what happened after that?
Well, the PSA went down to undetectable for about 6 months, and then it all started coming back rather quickly. And he wrote the rising PSA off to a lab error, and then they sent it off to salvage radiation, which was a big mistake. That damaged my colon significantly. And prior to that, I made a trip down to the Mayo Clinic in Rochester and even into Phoenix. And after they got a copy of my medical results, they told me straight up, had I come to see the Mayo Clinic in the first place, they would not have recommended a prostate removal, because at the time they would have been able to save my prostate, and I would have been cured of this nightmare.
Mm-hmm. So then what happened then? What's the continued saga that you have going on?
Well, in addition to all of this, there was some sideline problems. I ended up getting a divorce over this prostate cancer, and was being persecuted heavily by the Alberta divorce laws. So in any case, I started radical radiation, or salvage radiation, and that was, as I say, an absolute utter mistake, because they just do a shotgun approach, and by that time the cancer cells had already moved. And when I went to the Mayo Clinic, they did a choline C11 test, and they had found some hot spots in several lymph nodes. And I accepted the external beam radiation, and they just damaged my colon significantly, which again, I have to admit was an extremely painful operation.
And so that was not done at the Mayo?
No, the external radiation was done in Edmonton, because we have free healthcare up here compared to the US.
Where was the lymphodectomy? You said you had a lymphodectomy. Where was that done? At Mayo?
Well, they didn't do any lymphodectomy. They did a choline C11 test. And the choline C11 is similar to the PSMA.
Yeah, we're very familiar with it, Warren.
Right. So I guess I forgot to ask one question, Warren. What was your Gleason score at diagnosis?
Roughly 7.
Was that like a 4+3 or a 3+4?
My memory serves me right as a 3+4.
Okay.
That's a long time ago. I'd have to check my records.
Right, sure. So you had a C11 choline scan that showed potential lymph node involvement.
That's correct.
And so what happened next?
Well, as I say, I came back to Edmonton and started this external beam radiation, which was a big disaster. And then I had to have surgery to repair the damage to my colon, which again is extremely painful. And then when I was at the Mayo Clinic, I did an awful lot of questioning with those really, really nice people down there. And they were kind of moving into the immunotherapy field. And at the time in 2013, nobody knew the word immunotherapy. And I found out that there were several publications online that did talk about using existing viruses to control or kill cancer. And if anybody wants them, they can send them my email address. I've got them in an email. I'll send them the online videos, and they can look at it and make their own decisions. But in any case, I started on my own treatments using immunotherapy, and it worked very well to the surprise of my existing radiologist. And,
so what kind of immunotherapy did you do?
Basically, what it amounts to is using existing immunizations from things like shingles, that was the best, actually. The shingles was the best effective treatment, but all the DPT shots, any kind of an immune inoculation that you would have gotten from your childhood. Because one of the things that many of the researchers will say is you got cancer because your immune system somehow failed. You don't know why.
Well, Warren, we're really more interested in you than you educating us. We're pretty familiar with this stuff. What's his name? Moyad has been preaching this for years. In this forum several years ago, he advised everybody to get all of the immune therapies. So we are, we agree with you that there may be benefit. What we're really interested to know is where are you now and how can we help you?
Right.
Well, I'm still here in Edmonton. I'm still alive and kicking. My doctor has given up on me and told me that he's not going to help me anymore. So I fired that loser. I'm supposed to be getting another doctor that's going to be a little better. I am on abiraterone and prednisone right at this minute, and that seems to be working quite well. I had some 2 heart attacks due to the side effects of enzalutamide and bicalutamide, and I wouldn't recommend those drugs. And just prior to this meeting, I got an email regarding the PSMA test being approved in the US, and they were also talking about something called radioligand. And apparently that's a very similar treatment to the lutetium treatment. And I imagine that's going to be clinically tested or studied.
Right. So I mean, it's all true, but I guess, so what is your current, so currently you're on Abi and prednisone, and who prescribed that?
I was asked what I wanted, and they gave me those 3 options. The enzalutamide gave me a heart attack. Took about
Well, but
6.
I guess, I mean, is this come from the Mayo or is this come from your Edmonton doc?
The Edmonton doc.
And is this Edmonton doc?
When you say the enzalutamide gave you a heart attack, I mean, we know that LHRH drugs have a metabolic effect. And I assume that you've been on Lupron for a while, or Zoladex, or Eligard. Which one?
Well, the Eligard is the one, the belly shot, and that I've been on for quite some time. That would probably be about 2014 I got on the Eligard.
Okay, so it's probably a lot more likely that the side effects of the LHRH is what caused the metabolic syndrome, and the metabolic syndrome is probably what caused the heart. When we have a lot of guys here that are on enzalutamide, we've seen guys that have been on enzalutamide for years. I've never actually heard anybody say, well, the enzalutamide gave me a heart attack. I have heard people say, as a result of the metabolic syndrome, and doctors agree, from the LHRH drugs, which reduce your testosterone, that could cause heart complications. But Herb, you or Len, do you agree,
Well,
or
I
do
think,
you disagree?
Well, I mean, it's certainly more prone, from what I know, with Abi than with enzalutamide. And Len, would you agree, or?
Well, I think we know that stroke, I believe, is more common with enzalutamide.
Yeah.
I mean, if he had myocardial infarction, who knows? Maybe he had a clot that went to the heart.
Right.
But I guess these are things that are pretty difficult to pin down. It may have been a correlation, not a causation, Warren. You can't really be sure. But I'm curious, how long were you on enzalutamide?
6 months before the heart attack. One moment, gentlemen.
So I'm wondering, it's unusual that anyone would respond to Abi after being on enzalutamide, but we'll have to ask him that.
Well, I mean, it might have been, I mean, if you're on 6 months and you're still responding, it may be that you could still respond to Abi.
True.
Yeah. Warren, what's your PSA history? You haven't told us much about what happened when you went on the LHRH and when you were on the enzalutamide, and now where are you now? What's your PSA been doing through all of this?
Well, PSA about a year ago went from just about 1.5, jumped up to 10 in about 3 months. And that's when they offered me the enzalutamide. And prior to that, about 6 months prior to that, I was on the Eligard and on the bicalutamide. They offered me bicalutamide to start with, and that took only 2 days to put me in the cardiac ward. And even though I was heavily exercising in pretty good shape, 2 days later, I was having stents put in my heart. And then I stopped taking that, and my PSA still stayed low because I was still using the immunotherapy when I was getting inoculated as much as I could. Then after that, it took about 6 months. PSA started to rise to about 10. And then I went on the enzalutamide, and that's when I started getting a terrific amount of muscle pain. I went from being able to jog at about 6 miles an hour to getting to crutches. Then I was looking for a wheelchair last year, and a new doctor came on the scene and told me about getting off of that. So about 3 weeks after I got off the enzalutamide, I was back to jogging again.
I mean, I'm not, if you had a stent very soon after enzalutamide, I mean, that's again, I don't know that it's cause and effect. But all right, so now are you jogging now?
Yes, I am.
Uh-huh.
And
what's your current PSA?
It was about 2.8, and that was about 3 months ago. I get another one done on Wednesday.
Uh-huh. And have you ever had any genetic testing or scans?
They refused to do that for me. So that's my next step, the genetic testing. The PARP inhibitors are things I'm going to be investigating, as well as the PSMA test. And when I went to get a second opinion from the Mayo Clinic on getting the genetic testing done, my present doctor washed his hands of me and said, if I could get treated better someplace else, by all means, look it up. So at that point, I told him I will do so, and he can take a hike.
Is your present doctor a medical oncologist or a urologist?
A medical oncologist, both of them are. My new one, as well as the one I could let go.
Okay. And are they both based in Edmonton?
Yep, both based at the Cross Hospital.
Right. And do they specialize in genitourinary diseases, specifically prostate cancer?
They do.
They do. So what are their names?
I can't tell you their names because that would be rather discriminatory.
Well, here's the thing. A lot of people think they've got doctors who are GU Med Oncs, but when it turns out they're not, and there are very few GU Med Oncs in Canada. We know 2 or 3 of them. I've not heard of a GU Med Onc in Edmonton, but you certainly could prove me wrong. So generally what we do on these groups, people don't have a problem doing it, is we do name the doctors so we can find out if in fact they do have a genitourinary qualification, meaning they've done a fellowship in genitourinary disease. Did they do fellowships in genitourinary disease?
Well, okay, if you want to know the names, the guy I let go is a fellow called Basapa, and I did not check out his qualifications. He just works in the prostate cancer group, and he's the one I have no faith in at all. The new fellow I'm supposed to be getting is called the Dr. North, and I haven't met the fellow yet. I'll be meeting him in about 3 weeks.
Yeah, I mean,
well, I think that you've got to insist, you need to look at him and you need to see if he's done a fellowship in genitourinary medicine, because the guys, the oncologists who have not, they don't understand the treatment well enough. And it sounds to me like you're getting some bum advice. You know, I know it's difficult in Canada. Let me tell you, for example, you can get FMI, Foundation Medicine, next generation sequencing in Canada. I've done it with 2 or 3 guys. And if they order it, if they order it, then we can put you in touch with the Foundation Medicine support in Canada. And it will probably cost you very little, if nothing, even in Canada, because we've seen it. So we're speaking from experience.
Send me the information on who to contact, because I would like to do that. Because at this particular point, I know British Columbia has some good treatments available. although they would probably only treat people that are BC residents. But I even have friends at the Mayo Clinic who have offered to treat me down there if I want to get down there. Being the
Which
COVID
Mayo
around,
Clinic? Which Mayo Clinic?
Rochester.
If it were me, I would not be going to Rochester. They don't have quality genitourinary medical oncologists there. They have a couple, but if you want to go to Phoenix. We've got 2 guys on this call who go to Phoenix. The problem with Rochester is Quan. And so it makes it very difficult because he hogs all of the advanced patients and then he doesn't send them to the GU Med Oncs there. So you've got a very messy situation with Rochester in Minnesota. It's a much clearer situation with Rochester in Phoenix.
With Mayo in Phoenix. Right.
With Mayo in Phoenix.
Surprisingly,
you have Alan Price, you have Singh.
I mean, Warren, I guess my diagnosis here, I mean, it's not really a diagnosis, is and we say it to all of our guys, you need somebody competent who's able to guide you through this decision tree that's going to benefit you. And I think that's why we are so focused on getting people in treatment with a GU Med Onc that knows the story. I mean, you were given LHRH antagonist, but you weren't given a 2nd generation anti-androgen, which doesn't make sense to some of us. You have not had genetic testing, which, given the duration of your disease, should have been done. You need to have a scan to identify where the disease is. Right now, you don't know. And all of that is troublesome.
Funny you should say that, Herb, because I've told my doctors that many times, almost in those exact words. And every time I mention it to them, they turn cold and they walk away and they refuse to have technical discussions.
This is problematic.
You need to elevate.
And I don't.
So it's no good. Then either you're with the wrong doctor or you need to report them. I mean, we can't help you. We cannot help you manage your existing doctors. We can guide you on what to do, and we're happy to do that. But we cannot advocate for you to your doctor. You're your best advocate, and you can do it. I've been working with Canadians for years, and it's not as easy as here, but they have managed to get the treatment that they want. But it's difficult.
Oh, I agree with you.
Do you have dual citizenship, or do you pay out of pocket when you go to Mayo?
Well, I put a price on my life, and there's a pretty high price on it. So if I've got to pay to the Mayo, I'd be happy to do it. And I've received much better inspiration diagnosis from the Mayo Clinic than anybody else. BC is starting to come a close second, and I've had a lot of good success with British Columbia, as well as some of the people in Eastern Canada. They seem to know what they're doing. But it seems like we have an awful lot of people that are doing an awful lot of experimenting on new to the
Warren, I mean, be that as it may, I think the thing for you to do is decide where is going to be your primary treatment or primary decision maker. I mean, sometimes you can get a decision maker and somebody who's your sort of your quarterback, but yet the local docs will cooperate. And that's what I think you have to hope for, is really a trip to a really good GU Med Onc with, and Rick would say the place to go is Mayo Phoenix. I mean, there's other advantages to going to Mayo Phoenix when you're in Edmonton at this time of year. And maybe that's the thing to do. And find a GU Med Onc there who will be the quarterback. And if he picks up the phone and calls the guys in Edmonton and said, look, this is what I'd like you to do, I suspect they'll listen.
Well, I've asked them that and they've told me forget it. They said if I can find better treatment somewhere else, I should seek it out. So basically, any discussions I was having with other doctors has caused my past oncologist to wash his hands of me. And
Well, so let me cut to the chase, Warren, because we are running out of time, and ask, well, what are the major questions you have for us now that we've heard? We got a good sense of where you are. What are the questions you might have that we might be able to address?
Well, when I went to see this guy the very first time I had this Basapa fella, he walked in the door and he told me, he said, we're sorry, Warren, your cancer is terminal. There's nothing we can do for you. And there it is. And you can take your choice between 3 or 4 different drugs. And that was it. And they gave me the bicalutamide, the enzalutamide, the apalutamide, and the present one I'm on. So in that case, he said, when these drugs stop working, we'll go for the intravenous chemo, and that's it. And they refused to offer any other treatments whatsoever. And when I pointed out to him some of the treatments that I could find, he just said, forget it. I mean, you'll never get those treatments in Alberta. You'll have to seek out someplace else to get them if that's what you want.
Yeah, all right. But I guess, what are the questions you have for us?
Well, my question is, has anybody had any of these PSMA or lutetium treatments or the advanced treatments, and have they worked for them?
The answer is yes.
The answer, let me answer that. The answer is yes, several. Do we have anybody in the group today that has done lutetium? No. Yes, LATIMER. So we have guys in the group that are doing lutetium on a test basis. Somebody in your case, somebody in your situation, you probably need to have done chemo first, because you cannot get that without having done chemo. It doesn't sound like you've done chemo, so it might be something you want to get under your belt. Not attractive, but unfortunately, it's right now it's going to be probably required. We've had plenty of people who have done PSMA scans. I would say we've had people that have done most everything that is out there. Specifically, is there one treatment that you wanted to know about?
Nope, I just want to know about the one that works.
Well, the problem is that none of them work for a cure. There is no cure. So what you're looking at, and after all these years, I don't know if anybody's explained this to you, but this is a disease that you have to treat as a chronic disease that you have to manage for the rest of your life. At 68, you could go for another 20, 25 years if you can manage the disease. So you have to be looking always at what am I going to do next? How am I going to manage the disease? One thing that we would strongly suggest to you to examine, depending on how much metastasis do you have right now, Warren?
Well, I don't know. The tests they've always done have been inconclusive. As far as I know, I don't have any aches or pains or difficulties from the disease. I have had several problems from the treatments, but the disease itself has never been a problem. There's no problem.
When was the last time you did a CT scan?
The CT scans I've had pictures of, and they've all said they're inconclusive.
When was the last time you did a CT scan?
About a year ago.
Okay. And when was the last time you did a bone scan?
Well, bone scan was probably 2 years ago at least.
Okay. So one thing is, we strongly suggest you get at least the state-of-the-art scanning in wherever you are annually if you have metastatic disease. Do we know if you have disease in your lymph nodes?
If I do, I haven't been advised of it. Other than the Mayo, when the Mayo did their choline test, they told me that there was signs that my lymph nodes had it, but at this particular point, that's never been reconfirmed.
Okay, what is your current PSA right now? 3 months ago?
He said 2.8.
2.5. 2.8, 2.5.
Right, 2.5. So there are several things, but I think the first thing you've got to do is you've got to get an accurate picture of where your disease is, because that will determine what you do next. So if you want to spend your money on something, go over the border and get a Pylarify scan. They're readily available.
I would say, let's go back to a step. And I think, Warren, you need a GU Med Onc who will order these scans, interpret these scans, order the appropriate tests, and interpret them.
Unfortunately, it's not as easy as that in Canada. I do know that. I mean, you can't just find a GU Med Onc. And if you're working with the guys are you working with Kim in BC?
No, not yet.
Okay. Who are you working with in BC?
Nobody at this particular time.
Okay. So I would get yourself to one of the GU Med Oncs. There's a guy in Ottawa. There's, I think, a couple of guys in Toronto. There's a guy in Kim, I think his name is. I have it written down somewhere in BC. I'm sure you know of him. You need to get to these guys. You need to get a Pylarify scan. You need to get next generation sequencing. I've put the Foundation Medicine website in there for you in the chat window. You can go there and you can find, and on that, there's a telephone number, and they'll put you in touch with the people that provide you with support, and you can figure out between you and them. You'll have to get your doctors to sign off on it. They'll help you with the payment. They have a very good program for people in Canada.
Okay.
So, what I would say is get the basic information, and then we can talk about what the right treatment is.
Right. I think that's the solution. You need a Med Onc testing, and then we can move forward. With a PSA of a 2-something, there's time. Okay? Warren, have we lost you?
I step away.
Okay, but I think we do have to move on. And we will, we can help you find an appropriate GU Med Onc, and I think that's where you should begin.
Okay, sorry about the interruption. I'll look forward to hearing from you, okay?
Okay.
Well, what are you waiting to hear from us?
Well, where do you the names of these GU oncologists that you were mentioning?
You know them. You know the guys in DC. In BC. You know Kim. And the guy in Ottawa, I don't know. I got to go and look for it. But I got to tell you, if you know the BC guy, what would you rather go to BC or would you rather go to Ottawa? The guy in BC is the best.
What's the guy's name in BC?
I cannot tell you offhand. I'll look it up and put it in the chat window for you.
Okay, thank you.
Okay. Rick, I think we probably need to move on.
I agree.
Okay. Thank you, Warren. We'll be here for you. We'd like to hear more as you get this sorted out. Okay? We will move on. Harry, tell us what's up.
I was just looking maybe to get some advice or other members' experience with the secondary treatment. I had a recurrence end of last year, metastatic. I had 2 lesions on my spine, and I started on ADT again. I was on about a 2-year holiday, and so I also had radiation to those 2 lesions. In addition to Zoladex, I was on Erleada. Unfortunately, I had a mild stroke, and after all the scans and things, they couldn't find a direct cause, and it was determined probably best to go off the Erleada because that might have been a contributing factor or the factor, but it's hard to tell. So I meet with my oncologist, Dr. Hussein, tomorrow, and I'm sure we're going to have a discussion about what the other options are for secondary treatment. Initially, you know, I talked to her about apalutamide, enzalutamide, and what's the other one you take with a steroid?
Darolutamide.
Darolutamide, yeah. But now I'm a little gun shy after what happened with their LIDA. So I'm responding very well to ADT. It's basically my PSA is undetectable, but I don't know if I could just continue that way or if I should be considering a secondary. But I'm a little nervous about using a secondary drug after what happened.
Yeah, does anybody have any comments? I mean, what was your PSA at its worst?
Well, that's when I was initially diagnosed back in 2016. I was 14, and
then did you have chemo at that time, or how did they treat it?
No chemo. I had a prostatectomy. I had salvage radiation, and then I was on ADT for about 16 months. Then I took a holiday. Lasted a couple of years. Almost 1 year to the day after I went off my last injection, I had a PSA, a little bump that went up to 0.02 and then 0.04. It stayed at 0.04 for about a year, and then it slowly started moving up. And that's when I had the X-Men scan done and a bunch of MRIs and CTs and such, and they showed the two lesions.
So, Harry, so who's the quarterback for your medical treatment?
Dr. Hussein.
And he's in Houston. He's in Chicago. Is she a GU Med Onc? I don't know her.
Yes, she's David Muslin can talk a little bit about it. She's been around a very long time. She's one of the scions, but she's very difficult to work with. And she has her own views.
I know you say that, but I haven't found that. I mean, but anyway.
David Muslin, you're on the call. Would you like to talk a little bit about Dr. Hussein and your experience?
Well, you know, I don't want to talk about ripping a doctor. I want to get people's opinions of what I should maybe pursue.
Well, but I think it's all for us. What is this physician offering you? When you go to her, what does she tell you?
And let me just add, the problem, Harry, is that what she may offer you is not what's available. And if you want what's available, you can't get it from her.
Well, let me tell you what.
So what I'm saying is, why don't you listen to somebody who's had some experience? You seem to feel, and we've been around this block before, Harry, that we give bad, we're giving you bad information. We're not. It's based on what how other people have responded to her.
But you're not giving me a chance to explain what she has offered me. I thought I started to say that.
I will. Allow me to finish. If you try to interrupt me, I won't.
Go ahead, Harry. What did she suggest?
You're muted, Harry. I'm sorry.
When she, when I had the recurrence and it was metastatic, I went on ADT, and then I met with a radiation oncologist. They zapped the two lesions, and as a secondary treatment, we talked about enzalutamide, apalutamide, and I just can't remember that.
Abiraterone.
Yeah.
Abiraterone.
And so
Harry, let me ask you a question. When you said, Harry, when they zapped the two lesions, where were they?
On the spine.
They were bone. So that you had bone lesions and nowhere else.
Yes. And when I had the X-Men scan, my PSA had only gone up to the highest point was 0.7. But that's what amazes me. For so long, I had what was considered undetectable or 0.02, and yet I had two lesions. So You know, I have I wonder sometimes when we say undetectable, I think it's still in there doing its dirty work. But,
yeah, well, but Harry, so let me, I want to go back to say, so right now, you really, I think the best thing to do, from my humble opinion, is come back after you get this next PSA measurement. Because that's going to be an important indicator of where of potential issues. And you say it's tomorrow.
Yeah, but it's been so far since the reoccurrence. It's been, once I start ADT, it responded quickly and it's been undetectable. So that's been 6, 7, 8, 9 months so far.
Right. So my sense is, I'd like to hear in the future, you're a little more from the trend tomorrow after your next PSA measurement. And I think the guys will have a much better sense of what might be logical.
Herb, can I just share my experience with Hussein and what I went through? It's not really about her or her. Can I just? So Harry, so I was in the same spot you were in. I had 2 lesions on my ribs, and I got the choice of enzalutamide, apalutamide, and I forgot the other one. And I went through a process with her on these 3 drugs, and it was really, really hard. I went upside down. It took me a year and going through these different drugs and trying to convince her this not working is not working. And what Rick was referring to is I really wanted to get on darolutamide. I learned a lot about darolutamide in this group, and she held me off for a year. Finally, she said, okay, I'll put you on darolutamide. And so personally, I got very frustrated with her. I think she's really smart. She was always very nice. She screwed up. She got mixed up a couple of times, and she wasn't always consistent in the way that she was dealing with me. So I actually changed. I loved her, but I just was feeling uncomfortable, and I changed. But I think she's a very smart lady, but she's very, very protocol, rather than looking at me and noticing the difficulties I was having. So that was my experience with her.
Yeah, and I can't say I've shared that same experience. I'm sorry that happened to you, but I found if I come and meet with her and I'm prepared and educated, able to discuss things, that she's been very reasonable with me and open to a lot of different things. I mean, I've looked at the darolutamide, but it hasn't been used in my case, so I'm hesitant myself to try it because any of the clinical studies and things have not been used in my situation. So, I'm going with what's been tested in trials and things like that. So, and I don't know, I haven't had that experience. So,
look,
I understand
so Harry, I think my sense is that if you got your next PSA measurement, let's see where the trend is, and we'll discuss it in the future.
Well, how long is a trend, I guess?
Well, I mean, you said you had one 3 months ago, and you're getting one tomorrow. So let's see what huh?
This will be my 4th one since last year, since the recurrence and the evolve, since I started ADT, been undetectable. So I don't know how much longer.
Let's see. I think I personally think it'd be much easier to advise you with more data.
Okay. What's the magic number, I guess?
There's no magic number. It just, I think where it's going is going to be an important factor. And if it's stable and the drugs are working, it's one thing. If the drugs aren't working and it's going up, it's another thing. And you're so close to the measurement, next week we'll be here, you'll have the number. Right?
Okay. Yeah, I guess I just don't understand. I've been a year getting blood tests, and it's been undetectable on the ADT. So the ADT has been working as far as PSA goes. So
but sometimes
all is good, Harry.
Right. So my question is, because I was metastatic and had recurrence, should I be considering a secondary, combination treatment? That's my question. Nerlita, was an issue for me, so they took me off it. So I'm just asking for other people's experience with the other two, enzalutamide, and what the thought is if I really need a secondary, if my ADT, if my treatment has been keeping it undetectable. That's all I'm looking for opinions on.
Len, maybe
So
you could weigh in.
can I just share my experience, Herb? So I was on enzalutamide, and I went upside down cognitively on enzalutamide. I really struggled with that drug. And then I went on abiraterone, and I struggled a little less, but I was still upside down, really was struggling functioning and working and everything else. And that's when I wanted to try something else. So that was my experience. And my PSA has been, non-detectable. So I did good, but other guys go on those drugs and they're fine. And I think everybody has different experiences, and you got to try it and see how you feel.
Yeah.
If you're not feeling right, you get off it and talk to her.
Yep.
Can you tell me, I guess my question is, why did you, I assume you were on Zoladex or Lupron or something. Why did you decide to go on a second drug?
Because Maha Hussein strongly suggested it. And she said, you really want to get on a second line drug because you want to fight it. And it absolutely is true. And but I just really struggled on those drugs.
Okay. What is everybody else's feeling on a secondary drug? Do it feel it's appropriate?
It depends. I mean, Len, maybe you could comment, please.
Yeah, well, I think it is standard of care for someone who has metastatic disease that they should be on a secondary anti-androgen. Now, apalutamide and enzalutamide are nearly identical. And, if you didn't like apalutamide, you probably won't like enzalutamide either. So maybe a better choice for you would be abiraterone, unless if your doctor's able to get you darolutamide, that doesn't have the cognitive, brain fog that apalutamide and enzalutamide have, because it doesn't enter the blood-brain barrier. So that's your best bet.
But the Erlita, I wasn't having any problems with it that I knew of. They just took me off because they thought it may have contributed to the stroke. Otherwise, I felt fine. I wasn't having any really poor reactions.
Well, but that's an adverse reaction. If they think it can, again, we heard about someone who thought they had a heart attack on enzalutamide, and if stroke and heart attack are really the same, just a matter where the clot goes. So it's perhaps worth looking at another drug like abiraterone. But I think what Len is saying, and I guess what I hear from David, is yes, you should ask for a second line anti-androgen, just not the one you were taking.
Okay. And then the other one that was mentioned, the darolutamide, I think, I haven't seen any clinical trials or tests that it was used in people who were still castrate sensitive.
It's not approved for metastatic disease.
Okay. Yeah, that's what I
hear.
Harry,
and everything I've learned from talking to everybody in this group, if I had a choice, I would try abiraterone first.
Right.
No, I'm talking about darolutamide.
No, but abiraterone.
I'm sorry. I was just going back to that. Okay.
Darolutamide is approved for castrate sensitive, not castrate resistant.
I'm
but
not
non-metastatic.
Sensitive, not metastatic.
Darolutamide is approved for non-metastatic, castrate resistant. Right. But there is no such thing. So it's a Mickey Mouse. It's a Mickey Mouse approval, and we've raised this with Bayer. We've also raised it. Now this is important, Herb. We've raised it with Bayer. We've also raised it with Janssen because apalutamide has a similar approval. Janssen takes us seriously, and they're trying to figure out how to change the approval. Bayer will not talk about it, and it's a problem. Why is it a problem? Because darolutamide is the best drug that's out there, and the way to get darolutamide, and Mr. Spieler, you may be able to get it, is by doing a technetium scan that shows you don't have any metastasis whilst we know you do. And that is the way around it. But Maher Hussein is very resistant to talking about darolutamide with anybody unless they're non-metastatic castrate resistant, and nobody's non-metastatic castrate resistant. No one.
Well, I'll bring it up with her tomorrow, and I'll let you know next week what.
Yes, please do, Harry. I really want to move on, guys, please. Because we have a lot of, we're running out of time.
All right, thank you.
Okay. Alan Moskowitz.
Yeah, hi, everybody. Hey, I have a few questions about going on enzalutamide. I'm going to be starting that right after the new year, along with a few weeks later, along with Lupron for my castrate, hopefully sensitive prostate cancer. And this was really to deal with lung nodules, which, well, we couldn't biopsy them. I told you last time that this is most likely the source of my rising PSA. And I had, for those who don't recall, I did have a PYLARIFY scan which found them. My question is this. Do people take those 4 pills at a specific time of day where you have maybe the least amount of side effects or reactions? Is there something that's preferred? And have most people been able to manage with the 4 pills? And my doctor says if it, you know, if you have a big problem with it, he says you can cut it to 2 pills and get basically the same effect. So I'll take any thoughts on that first.
This is talking about abiraterone, Alan?
No, enzalutamide.
So, anybody have experience?
Well, I was on enzalutamide for 30 months, and I took it all at the same time when I'd get up, whatever time that was. I didn't find that it interfered with my sleep in any way at all. Some people do have problems with prednisone, which you take with abiraterone. Sometimes that makes them a little wired. But enzalutamide does not have that issue, at least not in my case.
Okay. And okay, and so did you take 4 pills a day? Has everybody taken 4 pills, or has anybody have to cut back to 2?
I don't remember, Alan. It's been quite a few years now for me. I took whatever the standard dose was at the time, and I took them all at the same time.
Okay. And then in terms of side effects, I mean, I talked to Carl separately, but in terms of side effects, any idea typically how long it takes for side effects to appear, if you're going to have them at all? I mean, a lot of drugs, you know, if you don't get them in a month or 2, you're pretty good. But I just wonder if that's the case generally with enzalutamide, or, you know, am I going to go 6 months or 8 months and all of a sudden, you know, these things are going to appear, whatever those are. Any thoughts?
If they're going to work, and chances are it will work within probably the first 30 days. I was on it for 30 months, and it kept my PSA down manageable for 30 months. And it didn't take that long to make an effect.
And did you have any side effects?
Well, David mentioned being cognitively upside down. I've been cognitively upside down most of my life, so I don't know if there was any side effects or not.
Okay, but you didn't have.
No, I really didn't. I didn't. I tried abiraterone. That didn't do anything for me. I tried apalutamide. That didn't do anything for me. But enzalutamide was my first second-line anti-androgen, and I didn't notice any real side effects from it, to be honest.
And so did you basically feel pretty good throughout your treatment?
Yes, I did. Yeah.
Right. And you were on.
I think there are people's experience are different.
That's
and
correct.
I think in the case with all of these drugs, people's experience are different. So nobody's going to be able to tell you what the side effects are going to be or how they. I mean, we've heard from David that enzalutamide made him a little bit, you know, and other people have said that has cerebral effects. Len has said that, and that's why Darolutamide is preferred in certain situations, but I think, Alan, you're just going to go with the flow and see what happens. There's no point in worrying about it now.
Yeah, no, no worrying. Just trying to get a heads up in terms of, what I might expect. I'll be on it probably a couple of weeks before I start the Lupron, and we'll go from there.
I mean, look, think of it this way. If we tell you what the side effects are and what you expect, you're going to feel them.
Yeah, right. I get that, Herb. Very, very clear. Very true. All right, very good. Thank you very much.
Okay, great. We'll move
Alan,
on.
I have a
Bruce.
question. Alan, I have a question for you.
Yeah.
Why, this is the first second line drug you're going on, right?
Yes.
Why did they choose to put you on enzalutamide rather than abiraterone?
Sure. I spoke to both of my MOs. They both want enzalutamide. They both had slightly different reasons. My main doctor at Sloan, he said to me, he believes enzalutamide is the more active drug. And we talked about, if you take one first and then you need the other, is a little bit less active, etc. He said, at the end of the day, he said, there's no difference, but he gives Abby to more elderly and frail people, and he gives Enza to younger and healthier people, because he believes it's the better drug if it can be tolerated, although it's not that much better in his opinion. When I said the same thing to Dr. O, I said, people said that, you should really do the abiraterone first and then the enzalutamide because of, the effectiveness, etc. He said to me, I don't choose my first drug by worrying about what the second drug is. And that was his comment. So they're both in agreement, a little bit different reason, but I did ask that because it came up last time. So I'm going to start on it, and I'm still presumably castrate sensitive. I did ask about the darolutamide, and they said I don't qualify. It's not approved for people who are castrate sensitive. They said I'll have a problem getting it.
Okay.
It's hard to get, but there are some doctors that can get it. Dr. O managed to get it for Len, but it is hard. But it's just that the evidence shows that at some point when you're done, which you will be with the first drug, and you move to the second drug, the abiraterone enzalutamide sequence seems to give you more time than the enzalutamide abiraterone sequence. Len, can you talk to that?
Yeah, that's true, Rick. Nothing I can add to that. Although I wanted to mention to Alan that the reason why Dr. O said he doesn't give enzalutamide, or whoever it was, doesn't give enzalutamide to his older patients is because there's a higher incidence of falls and seizures with enzalutamide than with darolutamide, and higher incidence than with abiraterone also. So
yeah, I guess at the end of the day, I'm going to go on it as planned, and if I have trouble or we have to change it, I'll deal with it. He said to me also, Dr. Chen at Sloan, he said there's never been head-to-head tests with these drugs. He says so you have to be very cautious when you're trying to compare them.
Right. That's exactly right. And there never will be.
That's right. Exactly.
No drug company is going to do it.
That's right. I agree. So yeah. So everything else is in my mind it's sort of anecdotal, or maybe comparing apples with different kinds of apples, and then we'll see. Anyway, that's where I am.
Okay, well, keep us informed. Let's see what happens when you start it.
Yeah, me too.
Good luck, Alan.
Okay.
Thank you.
Okay, thanks. Bruce, tell us what's up.
Yeah, I just want to let you know that I just finished up with 7.5 weeks of salvage radiation. 37 treatments. Went pretty well. First 3 weeks were pretty good. Then the fatigue started setting in, and really the fatigue in my case, I think, is the fact that like clockwork, every 60 minutes in the middle of the night, I got to go to the bathroom because obviously the radiation affects bladder control. So at going to the bathroom at every 60 minutes, obviously you're not getting a good night's sleep. So during the day, you know, very fatigued. So now that I'm done, I've got to wait five weeks. I'll do a PSA and then go see the doctor after that. And the hopes are that it's going to start decreasing. And if it shows signs of decreasing, that means they've radiated the right thing. And it should continue to slowly decrease from there. If there's no signs of decreasing or increasing, that means they missed the whole thing. So we'll see how it goes, and I'll keep you posted.
Good. Okay. Well, that's good. I mean, I think fatigue is typical.
Yeah.
But did you take a good walk or exercise after each one just to get some?
Well, for the first 3 weeks, I was fine. I was, you know, I ride a bike usually an hour a day, and I was fine and doing it. But I'm telling you, after week 3, I just was too tired to do anything. I'm back to bike riding again, but after that 3rd week, I hit the wall, and I just I spent the next 4 weeks sitting on the couch pretty much.
Okay. Thank you for the update, Bruce.
Okay.
Okay, Gary, you had a question. Gary Peters.
I did, yeah. Do we have somebody on the call who's really good diet and nutrition person? I'm asking because I had been trying to develop some tolerance for the taste of soy because I thought that was a good thing to be having with prostate cancer. And then I was listening to a nutritionist recently, and somebody asked her a question about soy, and she said, well, that may be okay with someone who's trying to prevent prostate cancer, or maybe has an enlarged prostate. But if you have active prostate cancer, you should not be taking soy. Does anyone know one way or the other about that?
I don't know. Peter, you're a diet expert.
I'm not a diet expert. That sounds like pretty hokey advice to me. I don't know. I would. I mean,
soy has estrogen. Soy is full of
estrogen. From UCSF, from Greta's book. It's pretty comprehensive, and I think she puts soy products in there. If you're a vegetarian,
I would like to.
Peter, what is that source?
Greta McCare from UCSF. I believe we have her our nutrition stuff on our website.
Yeah, there's a good PowerPoint.
MCCANN?
Just look on our website, Gary.
Okay.
John, did you have something to add?
Yeah, I think if I remember that UCSF reference is pretty old, but I'd have to go back and look. It's worth an update. I could do that. I would like to see her reference on that. I'm pretty skeptical as well. I can't believe that.
Hold on, guys, and I'll put it in. I'll put it in the chat window for you.
Okay. Thank you, John.
Gary, when you say soy, are you just talking about all soy products? You're talking about tofu or some sort of soy-based food supplement, or?
No, I guess the question was on soy milk. She said that, you know, soy like tofu or something that, you know, is solid and you can cut off a piece, that's not as bad, but she thought soy milk was a bad choice. And
I eat a lot of tofu, just because my wife is Japanese and that's what she cooks, but and she's a vegetarian. So I've had nobody ever tell me anything about eating tofu at the very least. I mean,
This is Alan. From what I know, I've been using soy milk for probably 7 or 8 years, and I don't drink regular milk. I have it literally every day, it's in part to stay away from dairy. But what I've read is that soy has not been shown one way or the other to be a positive or a negative with respect to prostate cancer. Now that's maybe going back a year or two, but maybe things have changed, but I'm not aware of it. And I sort of watch that because, you know, I'm trying to, you know, keep the dairy down, but not overdo it on soy.
Yeah. I was gonna say, I don't do the dairy either, but you know, alternative, I do almond milk. That, you know, if you're worried about the soy.
yeah. Len just posted in the chat window information from a study, and then he posted the study, the website underneath that basically is counter to what you said, Gary.
Well, soy produces estrogens or things that are similar to estrogens. Soy has estrogenic-like compounds, and so that certainly would reduce hot flashes. So but I don't, Gary, I don't think that it would be either. I wouldn't put it either way.
Gary, the Prostate Cancer Foundation also recommends soy as part of the diet for prostate cancer patients. So between them and the nutritionfacts.org, and someone else posted something, but like Alan, I mean, I've been eating soy for years. I'm a Gleason 9 diagnosed over 7.5 years ago, and my PSA is currently undetectable. So I don't think it's harming me. I don't think it'll harm you.
Okay.
Okay.
Thank you all.
Okay. Joel Blanchette, are you there? Joel's, I see a screen, no Joel. So Russ Hoover.
Yes, good evening. I have a question. Somewhere along the line, somebody was talking about a new thing called RLT, radioligand, RADIOLIGAND. Does that ring a bell to anybody?
So, I mean, it's a generic term for any radioactive compound that's attached to something that attacks cancer. And so, for example, lutetium would be a radioligand therapy.
Okay.
Right? And I think there are other things coming along like that. So that's the generic term for something that has radioactivity attached to something which will attach itself to cancer.
Okay, because a neighbor was talking about this, and you know, it was like third hand to him, and I'd never heard of the word or RLT, but he described it as, I take Lupron, okay? That knocks the testosterone down. And then I'm on enzalutamide, which in my mind runs around the system like the old Pac-Man game and kills everything else that it can find. And supposedly this was the new upgraded thing for the enzalutamide
Okay.
type family things.
No, enzalutamide is a receptor blocker. So in other
Okay.
words, androgen receptors promote, the activity of an androgen receptor promotes prostate cancer. Okay, so Lupron reduces androgens out of your genital system, and enzalutamide blocks androgens at the receptor. Radioligand
So
directed.
enzalutamide, pardon me?
Right. But radioligand directed therapy is an entirely different mechanism.
Oh, I guess I understood him to say that this was something that was just approved.
Well, it's becoming, we have several guys on lutetium, and that's what's coming along the pipeline.
Okay. How do I keep track of that? Just with you guys?
Right. We're right on top of it. When
Okay.
lutetium is approved for everybody, we will all have a big cheer. Right now, they're on hold because of supply and demand issues.
All righty. Okay. That's what I had.
Okay. Well,
Thank
thanks,
you.
Russell. Joel, tell us what's up.
Yes, after I saw Dr. Antonarakis back in 17 November, he predicted that my PSA would go up. At that point, it was 1.1. A week ago, it came back after another test. It went up from 1.1 to 3.4, which is the highest I ever had since surgery over 10 years ago. So today I spent 1 hour and 15 minutes in an MRI tube at the hospital, taking 2 MRIs back to back. My radiation oncologist wanted to take another MRI of my right neck and also my T9, because when I took the last bone and CT scan, T9 was possible site of prostate cancer. So on the 4th of January, I'm going to see the radiation oncologist again. And this time he's going to design a hockey type mask for me to go around my head that can be bolted to the true beam machine table, so I can't move my head at all, so that he can radiate with SBRT my prostate cancer to my occipital condyle bone in my right neck. So, so he's convinced, along with Antonarakis, that that's where my cancer is, based on my last PSMA PET. Antonarakis thought I had prostate cancer for sure, even though the MRI at Johns Hopkins said I didn't, because of my high SUV score. So then it's going to take him 2 weeks to map out the scan to my right neck, and he's going to, at the end of January, the last week of January, he's going to give me five treatments of SBRT with 1 day of rest in between. So I'm pleased with all this because I'm finally getting something done about my prostate cancer. The 1.1 to 3.4 worries me. That's a mighty big jump in 1 month. So that's basically what my concern is tonight. Anybody, I don't know why Antonarakis was correct. I'm pleased that he was, but I don't know why my PSA is jumping so wildly in 1 month.
Yeah, that does sound like a big jump. But I mean, I wonder if Antonarakis was sick.
First question I have, for you, Joel, is how did you convince the people in your area that this was prostate cancer? Because nobody on the East Coast has been willing to accept that what's going on in the occipital bone is prostate cancer.
Correct. The Metro Pet Center could not verify it. They thought it might be arthritis. But Dr. Eblin, my radiation oncologist, who Antonorachis knows very well, and he knows Antonorachis also, he was willing and able to accept Antonorachis' opinion on the fact, and he's the guy. He's the same radiation oncologist that took my cancer out of my left iliac. My second PSMA showed that he did a good job because it's no longer there. So Antonorachis was pleased to go with the same guy again, and I didn't have much convincing to do. Basically, the report that Antonorachis sent to Dr. Eblin, Eblin accepted with no problem.
Okay. Well, I'm very, very glad that you're getting treatment.
Yeah.
And I guess what we all hope is that that this will defer the hormone therapy for a little bit longer. Go ahead, Herb.
No, I think that's true. I mean, if radiation will do the job, that is pretty wonderful.
Yeah, plus I have a pain in my right neck, and the radiation oncologist said 80% chance that my pain will be gone after he finishes the SBRT. And the plan is that once that's done, he's going to take a close look at the T9, depending what the MRI says on the T9. And if he has to radiate that too, he'll radiate that also a couple, 3 weeks later. And then after that, both he and Antonorachis wants to give me another PSMA PET scan, a third scan, to make sure that they got all the cancer.
Good. Well, keep us informed.
Will do.
Okay. Stan Friedman, are you here?
I do, but I have nothing. Thank you, Herb.
Oh, Steve. Sorry, Steve Saft. You're next. Is Steve still with us?
Yeah, I'm here.
Okay.
I couldn't get on the picture before. I don't know if I can now. It looks, yeah, look, I'm back. Yeah, I had my fifth chemotherapy treatment last Thursday, and I continue to tolerate it really quite well. So I think I report that is important for everybody here, that at least for me, cabazitaxel seems to be not very toxic. And quite frankly, it's been easier for me to tolerate than the immunotherapy that I took from December through June, which was AMG 509. So that's the good news. The sort of other good news is that there's no evidence that my cancer is getting worse. And the bad news is there's no real evidence it's getting better. My PSA remains, well, the peak was November 14th at 140, and the last two times, which I get the chemo every 3 weeks, was 129. And a sort of a statistical anomaly was that precisely the same number 3 weeks apart. That seems never happens to me anyway, at that level. At any rate, so I'm really, I don't have a lot to say other than I'm hoping that the next time I Well, I'm hoping two things. I'm supposed to take a vacation January 5th. At this point, I guess the probability of really getting on an airplane and going somewhere on January 5th is probably pretty slim. But I'm not making any decisions until the time comes closer. And you know, for the time being, I've accepted that not getting worse is a good thing. And you know, it's hard for me to be patient, but I am talking myself into it. The other thing that I think that I'm going to do is I got my booster 5 months ago, and I'm considering and probably will get another booster sometime in the next week or two, on theory that you know, 5 to 6 months, all the things I read say it starts to fade away, and you know, I'm fighting one battle. I don't want to fight another one, but my report is just you know, really mostly about cabazitaxel, the chemotherapy. The anticipation of it was much worse than the actual experience has been.
Well, let's hope for, you know, sometimes these things just respond late. So we'll see.
Well, that's what I've heard, and that's what I'm hoping for.
We all are.
So thank you very much.
Where were you planning on going?
I'm going to Aspen. I have dear friends that have a house there, and I'm actually planning on skiing, to be sure, if I get there. But at this point, I don't, you know, it sort of feels like it might be too risky. Aside from the fact that my niece is 8 months pregnant, will be there also. You know, between the two of us, maybe we shouldn't be exposed to airports and COVIDiots around the world.
Right. Yeah.
So,
anytime.
Steve,
Yeah.
I want to say a couple of things. You know, we've been doing this a long time. Probably me the longest, Len the second longest.
Right.
We've seen a lot of people go through treatment. And as I wrote to you earlier on today, I can remember at least a couple of people where there was no response until after the fourth or the fifth treatment. And they kind of gave up, said, this ain't working for me. And the doc said, hang in, hang in. And then we did see a really positive response, but it just took a long time. And we're hoping that that's your situation. I don't know. Is there anybody on here now who has done chemotherapy, who waited a good period of time before they saw an initial response?
Peter, I see your hand going up. Yeah, you know, I've heard that and read that, and a medical oncologist says that, and so I've also had heard that sometimes there's a flare in PSA as cancer cells start to die. But I sure would like to see double digits on PSA sometime soon. But whatever, I am being patient, and I'm not, changing treatment anytime soon, although I'm signing up for a couple of different possible things related to, well, at least one that's related to the genetic testing that I did that is a specific treatment for P300 mutation. I don't know if I'll ever do it, but it takes time, and if, in a couple of months we don't see some response or there is some negative response, then I'll be ready. So
Peter, go ahead and maybe share how you responded.
Yeah, it took me several months to see change in mine, but you've got pretty high PSA, but my experience watching, working with other guys here at home is if it doesn't work, you're going to see the numbers really start to climb pretty fast after you stop chemo. But if they still stay around the same, they'll start dropping before long. Within 3 months or so, you'll start seeing changes. That's been my experience and guys I've seen here. But everybody's a little bit different, so hopefully you'll be okay.
Well, I'm rooting for that, and I appreciate you guys sending out the good vibes along with that too. And if not, we'll deal with it when the time comes.
Right.
Well, Steve, the other good news for whatever it's worth is that when this radionuclide, lutetium, PSMA, radioligand treatment, whatever you want to call it, that we talk about very, very often on this call, gets FDA approved, which it will pretty soon, there's a good chance it's going to require that you've done chemo first. Do you have to do chemo first? No, but that's kind of the way that the trials were designed. And so the FDA tends to go with the way the trials were designed. And you've got it under your belt now. And that's probably going to be the most effective treatment for you. And you won't be sitting there saying, "Oh my gosh, I got to get chemo before I can do it."
And the other thing is I feel pretty good. So, I mean, I'm quite surprised at that. But that's a pleasant surprise. And, in terms of other people that need to try chemo with respect to castrate-resistant metastatic disease, at least here's one person that found, almost everybody told me that docetaxel was something they really didn't want to do again or was horrible experience. And so far, I can't say that through 5 treatments. And I really, I was, really pretty good all weekend long. I had treatment on Thursday and, they shoot me full of 12 milligrams or 12 whatever.
But, I do want to say, Steve, that I think that's one of the benefits of having done cabazitaxel before the docetaxel, that people will argue about it, but the cabazitaxel definitely has a lower side effect profile. And if you can get your docs to give it you first, it's not a bad thing to do. The problem is that, again, it's back to sort of the theme of the evening, which is the sequencing and that we know that to get the most out of managing your disease, you do the docetaxel first, and then you follow it up with the cabazitaxel, and that's going to give you more time than doing the cabazitaxel. I don't know much about. I don't think I've ever known anyone that's done docetaxel after cabazitaxel and whether it has an impact. I just don't know.
I don't know. There's part of me that wonders if I feel too good for chemotherapy to be working. Like the cancer negative mentality is, something that I was never like this, but now I have a little bit of that in me, but I try to fight it.
So, okay. It's getting late, and there's a couple of guys that feel like they want to sign off, so I want to kind of move it along. Carl, tell us what's up.
Okay, quick update. I met with my primary care doctor on Sunday morning of all days, and he put me on several prescriptions, including a cream for the rash that I'm experiencing, which Dr. Tagawa believed it could be from the enzalutamide. I'm glad to hear there was a good amount of discussion concerning enzalutamide tonight, including potential heart issues, which now makes a little bit of sense that one of the medications that he gave me is a beta blocker. I'm thinking, okay, well, why am I getting that? But so that might now make sense to me that he wants me to go on that. Although the only issues I've been feeling that my most recently my blood pressure had been quite high, and it appeared to be really probably because of the, as I have mentioned, was on a cruise for a week and then came back that following week. It could have been all of the really good food that I had that could have caused the higher blood pressure. But also as the cream is supposed to help with the rash, which the primary doctor believes it looks like eczema. But again, you know, it could very possibly be relating to the enzalutamide, and also I have been having more balance issues, which again is relating to enzalutamide, and as several people have discussed the brain function, and I could add my hat into the ring with that. That has gotten somewhat worse. So what's going to happen next? I do have an appointment with my oncologist, Dr. Soraya, day after tomorrow, and I will discuss with him all of the things I've been feeling, the trial, the next scans being scheduled for January 25th as part of the trial, and with the next Keytruda infusion at that time. And I previously mentioned I sent an email to Tagawa where I said I expressed my concern and disappointment about the results, and he concurred. But he wants me to, no surprise, to continue on at least until the next scans, when it will be clearer as to what's growing or not growing. And I have mentioned last time that my PSA has gone up to the highest it's ever been at 52, and that had doubled from 6 weeks prior. So that's where I'm at. We'll see what Soraya says, and I have a feeling what Soraya is going to say is that hang in there, wait until January 25th when you'll have the scans and we'll have a clearer picture, but we will see.
Right.
That's my story.
Who did you see today, Carl? Which of your
No, yesterday on Sunday, I actually saw my primary care doctor.
Oh, your PCP, okay.
Yeah.
Okay. Given that it's late, Carl, we're going to move on.
Yep, nothing else. Thanks.
Al Latimer. Al, are you there? Yes, you are. You're muted.
Sorry,
you're not on.
Forgot about the microphone. Just want to report I got back yesterday for my 5th lutetium treatment at UCLA. I'm back in Florida now. It's actually my 6th or 7th time I went to California this year related to that. I met, while I was having the infusion, one of the doctors involved came in and he said they're not doing this program anymore, that they've stopped it, and they expect that the lutetium will be approved early next year, and they can, and hopefully it'll get approved by Medicare soon after that, and it can be, administered to a lot more people. In the meantime, I feel very lucky that I've got into the program. My latest PSA was 1.5.
Wow.
Down from 60 when I started. And we'll see where it goes from here. The doctor, Dr. Kwan, said that the PSA will probably continue to go down after the last treatment. My last treatment is in end of January. It may go down for another month or two after that, And at that point, I should have another PSMA PET, and we'll see where we stand.
That's great.
So, needless to say, I could hardly be happier right now.
True.
Those of you who are interested in, who was it? Somebody asked us early on about what these treatments can do. Al's a poster boy. They can be really, really effective. Not for everyone. You know, we're hoping to see the same results with Dennis McGuire. He was on a different type of protocol where he only got 3 treatments and they were more intense, didn't work so well, but Novartis has agreed to give him the extra 3 treatments. So let's hope that Dennis gets the same results that Al has gotten to date. And Al, it's just great. You know, I think this portends how effective the radionuclide treatment can be in the future for those of you who.
And what is the name of this treatment about? I'm sorry.
This is lutetium, Steve.
Lutetium-177 is what they call it. Side effects so far, after recently, the last 2-3 weeks, I've started to experience quite a bit of dry mouth. And I've been using these Xylomelt tablets to kind of counteract that, which seems to be working pretty well. I do have some fatigue too, but other than that, I seem to be fine. So far, anyway.
Al, can I ask whether you've gone through chemo before?
I did not. No, that I'm an exception to the rule. For some reason, when I got wind of this program through Dr. Schultz out in Marina Del Rey, and this was early on when they were just starting this protocol at UCLA, and they accepted me without having gone through chemo. But I understand after that they stopped doing that, and it was only people who were on chemo, because that's how the trial had been designed.
Right.
That people had
Vision
been on chemo first.
Right. The Vision trial had chemo as part of its requirement, and so I think the approval will probably include that because it was included in the trial.
Now, my PSMA PET scan, I did not have any bone mets. I did not have any organ mets. It was only lymph nodes. So, you know, everybody's going to be different. I mean, I think in the trial, generally, they were happy with more than a 50% decrease, and I'm over 95% now. So, I'm
good for you.
Just amazingly lucky.
One of the interesting things with you, Al, is that you're germline BRCA, and so you know it shows that BRCA, even with the BRCA mutation, it responds to lutetium as well. If you have questions, that it does respond. One thing I want to make clear, you don't need the chemo to make the lutetium work. That is just how it was sequenced and when people got it, because the people that were getting it were pretty far down the line. And like with many trials, they tend to give it to people with the worst disease first. And then we have to wait and work to bring it back. And it may be that lutetium works for people with low-grade disease, even active surveillance.
Well, I mean, there are trials now, including.
You would think so. The less disease, the better, you would think, as long as you're PSMA positive.
Al, give us a little holiday cheer and tell everybody how many years you've been working on this disease.
Oh, well, I alluded to that earlier when Eric was on the call. I think it was Eric, and I told him this week, actually 26 years ago this week, I had my radical prostatectomy. So I've been doing this a long time.
Okay, I want to, we do have one more person. Jake, we'd like to hear from you. What's happening?
Okay, thank you, Herb. I'm sorry it's so late, guys. Several people have, for those of you who listened to my description last week, I'm on hospice, or I'm getting ready to go on hospice, I think. And they had a couple people reached out and asked for a status. The hospice is going to come visit us tomorrow night, either late afternoon or tomorrow night. I'm not sure exactly when. I hope it's a medical person rather than a social worker, because I do have some medical issues. You know, I need to get my port flushed. And I now have, Peter asked about this last week, and I told him I didn't have any bed sores. Well, I was lying. I did have a bed sore. So I'm hoping they can treat that. Right now, my wife's putting some antibiotic cream on it, you know, in lieu of anything better. So that's basically it. I really don't have any news other than I won't have news until tomorrow, and hopefully
Well, Jake, will these people do palliative care, or does it have to be, quote, hospice?
Well, that's one of the things I want to talk about, Herb. You know, the palliative care, home nursing care, and hospice are kind of all on a continuum. You know, and it depends on the definition. So I think palliative care in my case is the more appropriate thing, because I don't think I'm quite ready to die yet.
Right. So I think this is something you got to tell them. You know, you got to be the advocate for palliative care, and I think you should get it.
Well, and that's what I mentioned last week. You know, is these people going to push surgery if they're a surgeon versus radiation if they're a radiation guy? Hopefully the hospice people also do palliative care, because like I said, it is a continuum. It's just basically the big thing that I understand as far as hospice versus palliative care is the way Medicare approves it. If you're defined as hospice, then Medicare will no longer pay for certain medications. And
right. But on the other hand, I mean, here in Montgomery County, there's one agency that does both.
Who is that?
So I don't know what. So in Montgomery County, one agency does both palliative care and hospice.
Do you know who they are, Herb? The name?
I can look it up for you and I'll get it to you.
Okay. Yeah, I'm not committed to these people by any measure. I just
are you in Montgomery or Prince George's?
Prince George's.
Yeah, so it may be different, but we can find out. Anyway, Jake, I'll write to you privately.
Okay, thanks, Herb.
So look, guys, I want to close up and wish everybody, for those that are celebrating Christmas this week, Merry Christmas. And I won't be around. I won't be in the chair till next year. So I wish you all a happy new year as well. And, you know, thank God it'll be the end of 2021. 2021 is kind of the year that goes down in infamy. Nobody can say, I don't know if anybody can say anything good about 2021.
Hey, I had an awesome year.
Well, good. That's great. But
that makes one of us.
That makes one. I think the rest of us look like, you know, this is a year we all want to forget.
You said that about 2020.
Yeah, we did. Anyway, thank you very much, everybody. It's a very high level meeting and really enjoy it.
Herb, Sylvester wanted to say something.
Huh?
Happy holidays.
Happy holidays.
Right.
Thank you.
Happy holidays. Merry Christmas.
Yes.
Good job, Herb.
Good night, all. Thanks, Herb.
Herb, could you just hold on 1 second? I need your help for a second.
Good night, all.